It's a real pleasure to be here, and thank you to all of you for all the work that you do. You know, it's very easy for me as an academic sitting in university looking at, lofty ideals of evidence, but it's you who actually delivers the work. And I've been very lucky and very grateful that I've been able to meet groups like yourselves over the years, so thank you very much for all your work. And just a few declarations. I don't have any conflicts of interest. I think it's always important to talk about these in today's world. Today I'm going to talk about two key things. Now, originally Brian asked me to focus on the evidence base around what works for prevention and social reintegration, and I'll touch on that, but there's already some fantastic resources out there published by the Health Research Board, amongst others, which goes through programs and interventions. And I think it'd be a bit dry of me just to repeat all of that, although I will touch on a few key issues. Instead, I'm going to take the liberty of focusing on the first issue, and particularly inviting you to think about drug use, particularly prevention and social reintegration in a broader context, probably reflecting the sort of work that you do and go beyond simply looking at drugs as a chemical or pharmacological issue. And I'll describe what I mean there. And this reflects some of the work I've been doing for the Advisory Council on the Misuse of Drugs in the UK, which informs government, where we've been looking around vulnerability in particularly high-risk groups and trying to promote and present a bit more of a complex and nuanced view to drug use. So I've taken the liberty of including some of this as well. I think it's something which will be very relevant to today's programme. But just focusing on young people in particular and what young people are concerned about today, and therefore what we as providers or academics should be looking at. Now, I think it's fair to say that the modern world for young people is becoming ever more complex, and some of the issues that perhaps we were concerned about or perhaps are concerned about as parents or family members today may not necessarily reflect young people's priorities and concerns. So this is data from Britain, but I'm sure it's very similar to here in Ireland. That although, for example, young people are concerned about substance use, drug and alcohol use, they also have lots of other priorities and lots of other worries that perhaps we don't consider so much when we're thinking about how we support young people. And I think there's certainly advantages of thinking about how we can link some of these issues together. For example, what are the relationships between substance use and social relationships and family breakdown? How does substance use interact, for example, with negative stereotypes that many young people feel? And certainly many young substance users, and certainly adult substance users, experience as well. So I think when we're thinking about substance use in the lives of young people and young adults, let's think about other issues that of concern as well. And when we're thinking about prevention, which I'm just going to focus on in the beginning of this talk, then perhaps we should also think about an expanded definition of prevention as well. So when I give talks, when I talk to my students, I ask them to give me what they think prevention is about, and they always focus on the drugs, and rightly so. Most of our prevention interventions are focusing on trying to reduce drug use. But the issue is, well, why are we doing this? What is it about substance use in and of itself that we're concerned about? And I would argue that it's not necessarily the acute and chronic health and social effects of drug use, although that's very important. It's about all these other attendant issues which are associated with substance use that mainly have those real-world impacts. And I'll give some examples in a moment. And I've always argued, and this is certainly my personal view, that the reason why we want to intervene, particularly with young people's substance use, is not because drugs are controlled under law, but because we want to reduce the probability of adverse health and social outcomes directly or indirectly associated with use. So back to my original point, what role do drugs play, what role do substances play in young people's lives, and how does this interact with other issues that they're experiencing? And if we have a look at an example for cannabis, so cannabis is a controlled drug. In the UK, it's a Class B drug. I'm not sure of the schedule of control here in Ireland. But the reason why prevention is important around cannabis, and it was really interesting to see there's a poster presentation on this later on, which I'll take a look at, is that, yes, cannabis in and of itself is harmful, but it's also associated, for example, with tobacco use. It's associated with multiple vulnerabilities. There's a complex relationship with educational outcomes as well. And there's a lot of debate in the academic literature about what comes first. You know, is it cannabis use leading to these issues, or is it these issues leading to cannabis use? And I don't think that's necessarily important. For the many young people who are using cannabis, for example, and who are experiencing these additional issues, it's the cannabis use which primarily alerts program providers and treatment services to the young person. But there's these whole other issues which are happening as well. And I think too few of our interventions actually address some of these key co-occurring issues, cannabis use in its broader context. And the reason why I think this is important as well, some graphic designer has been waiting 20 years to produce this. You know, policies are changing internationally. And we need to think about, well, how are our prevention and treatment and social reintegration services and interventions going to respond to this? So changes in national policy, so legalization of recreational markets in Canada, suggest a shift in social norms, but all of those issues that I was talking about before, the relationship between cannabis use and broader issues, they're not going to change. There's still going to be concerns around that. So how do we actually develop new and responsive prevention and treatment programs in new policy horizons? And of course, this isn't something which is simply restricted to North America. The Irish Prime Minister, you know, is actively considering this. And I know a few years ago you had a very progressive drugs minister who had a particular agenda around this. This is something that we need to face up to. How do our interventions and responses to drug use change with changes in policy? There's been shifts in behaviours around drug use. So this is just looking at European data. So this is just looking at changes with time. This is from the SPAD survey, which is a survey of school children, 11 to 15-year-olds. And looking at youth cannabis use, there's been no changes really over the years in that. Cannabis use is relatively stable, but more adults and more young adults are actually presenting to treatment services for cannabis use. So something interesting is happening there, that the nature of use is changing, and the problems that people are experiencing with cannabis are changing as well. So perhaps some of the original justifications for our interventions and the targeting of our interventions also needs to change. Perhaps it's less of a focus on prevention of cannabis use per se, but perhaps preventing the escalation from use into more problematic patterns of use. I don't know, that's just a suggestion. This, again, using the cannabis example, we know looking at the more intensive users, there's a close relationship between, for example, daily use and heavy daily use, with a whole range of perhaps more concerning physical and mental health disorders. And perhaps by focusing within those daily users and more heavy and intense users, we can begin to address some of these co-occurring issues as well. And again, we have some workshops on dual diagnosis. So prevention and treatment is not just about the drugs, it's also about other things which are happening in people's lives. And something which I'm very, very interested in, although I've not quite resolved how we address this. And again, this goes back to my point about understanding drug use in context, that for me, one of the biggest public health gains that we could perhaps achieve is breaking that link between cannabis use and tobacco use. You know, that's something which is quite controversial, but we've been relatively successful in addressing tobacco use in our populations, you know, public health success. But we've been less successful in breaking the link between the use of tobacco and cannabis joints. So originally, prevention interventions would be focusing on preventing the use of joints per se, but can we actually think about looking at this differently and actually saying maybe a more healthier or perhaps a less harmful perspective is to break the links between tobacco and cannabis? I think there'd be some real public health gains there. And again, prevention and treatment interventions have not really looked at this. And one way that I've viewed prevention, and in my talks I try and promote this, and in the report that we did for the Health Research Board, this is the model that we presented. And it's about understanding how all of our responses to substance use exist on a continuum. I think traditionally we've often thought of preventative activities as being separate to treatment activities and separate to social reintegration activities. But they exist on a continuum. And I think as we look at some of those determinants of substance use and some of the harms emerging from substance use, this is particularly useful. And I don't think it provides any advantages to think of prevention as separate from treatment and social reintegration. Certainly, it's often considered that way in commissioning and funding of services. But I think when we're looking at planning and developing our prevention responses, we need to try and understand how this interfaces with treatment as well. And one perspective that I found particularly useful, and I mentioned the ACMD report, which will be hopefully published by the end of the year, is to try and begin to integrate all of these issues. And I think it's particularly useful if we're thinking about moving beyond simply the use of substances to think about drug use or alcohol use from a life course perspective. So I think it's often useful to look to schematics. So if we think about an average lifespan, and here we have that on the x-axis, and within that lifespan, a certain proportion of the population will use substances. For those who continue use, there'll be some who have regular use. There'll be individuals and populations whose use will fluctuate. And we know that for some people, because of various risk and protective factors, some people will escalate into more harmful use categories. But taking this perspective of substance use across the life course, we can begin to think about, okay, what are the factors which potentially might determine those transitions or escalations into more harmful patterns of use? And do we have any interventions or treatment approaches which take this into account? So a lot of public health research or psychological research into genetics and personality factors has established quite strong and robust links between early years experiences, including prenatal experiences, and subsequent patterns of substance use. And we also know that there's lots of risk factors which predict the transitions from these perhaps more stable patterns of use into more harmful use categories. And essentially in our prevention interventions, we're trying to prevent this escalation. Now, leaving that aside for one moment, the question therefore is, well, what do we actually do about this? And this is an exercise which I always do with my students every year. You might have come across these top 10 alternative tips for health. And we talk about, okay, what is the best thing that we can do to prevent drug use or harms from drug use? And inevitably, the answer is, well, we need to prevent poverty. And you can imagine going to your GP and saying, oh, can I have a prescription for a satisfying, long-term, well-paying job? And certainly in public health, a lot of the issues that we're focusing on are simply products of poverty. Now, this is important when we're developing our responses to substance use, that this is not, joking aside, this is not to say that this is the only way to do things, but we need to understand that substance use, like many other health and social issues, have really important social determinants, whether that's poverty, whether that's housing, whether that's inequality. So therefore, just like we would with obesity, or lack of physical exercise, or cancer risk, we need to think about this broader context and broader determinants of substance use, move away from actual substance use practices into these key determinants. For example, some really neat analysis done by some French researchers. They looked at the impact of economic recession on substance use patterns in the EU. This particular analysis, they were looking at young people, and they showed that an increase of 1% in regional unemployment rates was associated by an almost 1% corresponding increase in young people's cannabis use and a 0.5 percentage point increase in use of novel psychoactive substances. Now, these are key fundamental issues which are beyond the control of the individual, hard to intervene with, and rely on public policy responses. So really interesting to see the fact sheet from the Realist Review, which focus on public policy responses. And I often think that perhaps when a lot of community-based responses to drug use is focusing on community mobilization and getting young people interested in developing responses to drug use. Equally, we might also say that getting young people involved in politics and encouraging young people to vote and helping to be part of political change might also be an effective response to drug use. And when we broaden out our understanding of drug use, and if we look at these sorts of risk factors in inverted commas for substance use, and we begin to understand how these risk factors are also associated with lots of other so-called problem behaviors and disorders. So the Lancet journal, a high-class and well-respected medical journal a few years ago, looked at the determinants of healthy adolescence, and particularly looking at those common factors which could improve the life chances for young people. And as part of this series of work, identified that the same risk factors for early onset of substance use, escalation of substance use, development of problematic substance use, were almost exactly the same risk factors as they were for development of mental health disorders, or educational dropout, or lack of engagement and employment, etc., etc. So this is really my call and my plea that when we're thinking about our responses to drug use, let's think of the bigger picture. Let's try and maximize our impact on the lives of the people that we work with. And this is something that I came across right at the start of my career, 17 years ago. And I remember seeing the presentation, and this was looking at how substance use fitted in with a whole series of other complex societal issues. And this had a big impact on me, because my background was in pharmacology and psychology, and I was very much interested in very neat cause and effect linear relationships. But then, as part of this presentation that I went to, beginning to say, what is special about drug and alcohol use? Well, it's special because it can have quite significant health effects. People die from overdoses, etc. People can be arrested and imprisoned. But actually, it's part of a spectrum of issues that many people face. And often, some of our most vulnerable members of the population are facing all of these together. And I suppose this is a plea to think about our responses in a bit more of a complex and complicated way. And this is not saying that we should attempt to address all of these different pathways, but if we can think about some of those earlier pathways, some of those earlier intervention points, then not only will we have an impact on alcohol and drug use, but we could also potentially have an impact on other issues that vulnerable groups are facing as well. And some of the work that we've been doing in Liverpool, although it's not unique to Liverpool, it's an international history of this, I think really clarifies this. So we've been doing a lot of work around adverse childhood experiences. So I'm sure many of you know a lot about adverse childhood experiences, but these are serious and chronic stressors which affect families and family homes and environments. And there's been a lot of work trying to understand how early experiences of adversity affect adult outcomes. And I think this work really clearly highlights the point that I'm making about stepping beyond drugs. So this is work by Bellis and colleagues. So Professor Mark Bellis from the University of Bangor and Public Health Wales. And they've been doing work asking individuals about early experiences of adversity. So adverse experiences include trauma in the family home, perhaps sexual abuse, physical violence, a parent who's imprisoned, and what impact this has upon adult outcomes. So we know that young people who are experiencing multiple clusters of these adverse experiences are, for example, 11 times more likely to have smoked cannabis, 16 more times more likely to use crack cocaine and heroin. This is in a Welsh population. I'm sure it's very similar here in Ireland or other parts of Europe as well. The reason why this is important is because unless these sorts of issues are addressed, it can lead to a self-perpetuating cycle of adversity. So young people who experience adversity in early years go on to become the parents and creators of family homes, which perpetuate environments of adversity as well. So it's perpetuated to the next generation. Now, responses to adverse childhood experiences, even though they can have a profound impact on substance use, aren't about drug prevention interventions. They're not about education or harm reduction. It's trying to address family homes, early years, adversity, and can have some lasting impact. I think this also has some lessons for some of our policy responses as well, particularly some of our criminal justice approaches to substance use, and the fact that punishing people can't reduce the impact of adversity. It only makes it worse. And another perspective that I found particularly important, this is probably not novel if any of you have ever read or been to taken a public health course or a social work course. This is, fundamental information that I think when we begin to look at individual behaviors, such as substance use, in the wider context that people live their lives, it actually compels us to think about our intervention responses in a bit more sophisticated way. So this is what's called a socio-ecological model, and it's represented in many different ways and has very many different names. But essentially what this is saying is that health behaviors and health behavioral choices that an individual makes has to be understood in the context of the relationships that individual has with other people, with their community, with organizations. And those relationships are also shaped by institutional factors, for example, access to services, access to treatment or preventative interventions. And overall, this is in the context of national and international policy. So the recession slide that I mentioned before. And I think when we begin to think about substance use and drug use in this context, again, we can begin to think a bit broader than individual choices and individual behavior change. So just as an example, just to illustrate that I've mentioned here, so applying the socio-ecological model to young adult drug use, so at an individual level, we know genetics, personality, and mental health are important, but young people's relationship with others. Prevention has often been described as a way to promote positive socialization between young people and families and communities, right up to what we're doing at national level on housing and employment, or even drug laws, impacts upon individual health behaviors and choices. So again, back to my point, not just about individual behavior change, what's happening at a policy level. And some places have done this really nicely. So you might have read in the news or seen on TV or on the internet over the last few years about what they've been doing in Iceland. So the so-called Iceland model to prevention. So Iceland is as you can tell, it's a closed island. It's small, relatively small population of 350,000, mostly concentrated in Reykjavik and a couple of other cities. But here they've taken that socio-ecological approach, and they decided as a country, because they were so concerned about historically high levels of youth drug and alcohol use and antisocial behavior, that they were going to do something about this. So they took this whole ecological approach, they implemented schools programs, they provided young people with €500 sports voucher each year. They got families involved in schools. They helped schools to develop new policies and ways of working around substance use. They supported community groups to develop health and prevention responses. They even got and I'm not sure how well this would work in Ireland or the UK, they even got young people to sign behavioural contracts, and parents would patrol the streets after curfew at 10 p.m. at night, telling young people off, or out after the curfew. Some elements don't work, but I think this is a good example that if you take this broader perspective on drug use and other health issues, you can have an impact. And all the surveys are showing that Iceland's drug use has plummeted. And even, cheekily, the mayor of Reykjavik was even claiming that this system is the reason why Iceland thrashed England in the football at the World Cup. I don't know. It can be done. It's difficult, but it can be done. And that's an example of that. It's even can be done on an individual school level or community level. So for many years back in England, we had what we call the Healthy Schools program, which was taking that ecological approach and applying it to a particular institution. In this sense, a school, example of school. So right from drug and alcohol policies in schools, about fostering pupil communities and pupil forums, as well as prevention curriculums, making links with community providers and services. It can be done on different levels as well, not just on a national level as they did in Iceland. And just to reiterate my points, this is something, apologies for repeating this, but this is something I think is really important, particularly if we're trying to develop intervention responses, that by moving beyond the individual and individual behavior change, we're reminded that that individual choices around drugs and alcohol are not simply a rational choice of the individual, but those choices are shaped by the opportunities, constraints, and influences of a wider environment. And many of those influences, young people and young adults, don't have any control over whatsoever. So this is also important because I think if we take this broader perspective, we're less likely to blame individuals for behavior, health-harming behaviors, including substance use. This is not to say that we're all automatons, simply a product of our environment. It's not saying that at all. We still need to take responsibility for our choices, and I do appreciate, there is sometimes a need for criminal justice and police interventions and making people take responsibility for their actions, but it's recognizing that these health choices are rarely rational. I think that's an important point. And another thing as well is to, when we take this ecological perspective, and if we begin to acknowledge that responses are needed across multiple layers of society, levels of society, then simultaneously we also recognize that some of those harms are also produced by those different levels in society as well. Those social and political institutions also play a role in producing those harms. Okay, so that was an extended introductory remarks, but I thought that was particularly important when I now go on to say a few words around evidence for effectiveness of interventions. Now, I've been giving talks like this for 10 or 15 years now, and I do appreciate colleagues and delegates are interested in these sorts of things, what works. But I hate to disappoint you, but the evidence doesn't really tell us a great deal about what works, or the evidence in its current form, which is why I really like the realist approach, moving beyond simply asking, is something effective or not, but actually understanding, well, what are those particular contexts, what are those particular relationships which make a particular approach work for some people and some groups and not others. And I think as scientists and academics, we've been very guilty in the past of not paying a lot of attention to those sorts of issues. So a lot of the evidence about what works, including in the evidence review that we did for the Health Research Board, takes a rather simplistic view of this. And that's not to say that this work isn't valuable. It is, I think it is. And we need to know in particular about where we should focus our attention and resources, but we don't have all the questions. We don't have all the answers. We have lots of questions. So I'm just going to focus on some of the findings from a couple of reports that we did. The one that we did for the Health Research Board to support development of the strategy, but also going back a few years as well for work that we did for the European Union, looking at social reintegration practices, both of which were informed by this broader ecological perspective that I mentioned. And for those of you who are particularly interested in the prevention side of things, then NICE, the National Institute for Health and Care Excellence in England and Wales, published some nice guidance. And even though it is for England and Wales, I think it's very relevant for Ireland as well. And it focused on core principles about developing skills, how you embed services within the community. So what do we mean by evidence-based? This seems like quite an obvious statement. So evidence-based prevention or evidence-based social reintegration is the use of systematic decision-making processes which have been shown through available evidence to improve outcomes. That's a very technical description. And a lot of what we know about effective interventions have relied on so-called hierarchies of evidence. And for those of you who've taken particularly courses in prevention or treatment interventions, might have been told in the past that the pinnacle of evidence is a randomized controlled trial, and we can't draw any conclusions unless we spend €2 million on the randomized controlled trial lasting 5 years. Yes, that's important, but I think it's also important to take a broader perspective on evidence as well. And evidence might also include evidence from experts by experience. It might also include practice evidence. And it might also include evidence from the relationships that we have with each other and clients and target groups as well. But I think the key thing for me is that when we're considering what to do, that good intentions aren't good enough. And I think certainly in the field that I've mostly worked in around prevention, I think quite often we've substituted good intentions for good work and good practice. I think sometimes many well-intentioned people think that it's better to do something rather than actually to be cautious and actually think about, are we doing something well? And we have lots of examples of interventions which unfortunately have had negative boomerang effects. Faces of meth or faces of addiction that they have in the USA, for example, or some mass media programs. Another reason why it's important is because we're in constrained times. So I've been doing some work recently looking at trying to make a case for the cost effectiveness of prevention interventions, trying to persuade policymakers that it's worth investing in prevention. So this is data from the OECD, and this is looking at the proportion of health expenditure that's allocated to preventative services, not just drug prevention, but also mental health and obesity, etc., etc. And almost in keeping across European countries, that we're only spending about 3% of our annual health budgets on prevention. And we're spending 97% or thereabouts on treating the effects and consequences of ill health and poor health behaviours. Now, of course, in the ideal situation, that ratio would be reversed. But, let's get real. Let's live in the real world. So with such small and diminishing budgets, so in the United Kingdom, our drug and alcohol treatment budgets have decreased by 30% in the last 8 years. So in a world of decreasing budgets, we really need to be very sure that where we're spending our money and where we're commissioning services is going to have an impact. So we do need to pay attention to effectiveness despite those caveats that I mentioned. And interventions that we deliver are often invisible, particularly prevention interventions. If you look at drug strategy, if you look at health and social care strategy, prevention interventions are very, very rarely labelled as such. And this goes back to that, the socio-ecological perspective, or even a life course perspective, that a lot of things that might be effective prevention interventions won't be labelled. So having a good, solid relationship with friends and family members, keeping people in school, having a training and employment policy which means that young people feel hopeful and optimistic about the future. These are all prevention interventions, and we know from all that work that I demonstrated can have a really positive impact on substance use and the development of disorders. But we rarely think about those sorts of activities as preventative activities. And my colleague, Dr. Zili Sloboda, who's a very eminent prevention researcher in the USA, and she describes that prevention in particular, and this can be extended to recovery and social reintegration, is everywhere. You know, it's in the classroom, it's the activities of the police, it's in the home, it's in the workplace, it's in hospitals. You know, even fire officers are now doing preventative work. It's in our environments, it's religious communities. Prevention is everywhere, but it's very, very rarely labelled as such. And we don't have evidence on this broader perspective on prevention. That's a real gap. And we have a lot of emerging health issues that we simply don't have evidence on at all. So something I'm particularly concerned about at the moment is around issues around body image and the use of dietary supplements. So in the UK, there's been a number of deaths associated with a drug called DMP, which is sold often to young women, but also young men as a dietary aid. And this really taps in not just to issues about prevention, but a wider perspective on body image and young people's health and well-being as well. Steroid use, our department has done lots of work around anabolic steroid use. We have very, very little evidence about what works around reducing harms around steroid use. Most of the evidence is limited to professional athletes and sanctions and testing. I think we've also failed to address issues around changes in drug markets. So I asked one of my PhD students quite recently to buy me some drugs online. He didn't do it in reality, I hasten to add. You know, just to see what's available. So Xanax, alprazolam, a very potent anxiolytic drug. In the UK at the moment, there's lots of concerns about young people using this prescription medicine. And you can very easily online, this example at the bottom, you could buy 1,500 tablets of Xanax, alprazolam, for about €800. So markets are changing, and I don't think as a field we've actually begun to address this. We've not really go to those locations where people are buying and purchasing drugs. There are some innovations. So a program that I really like is the Climate Schools Prevention Program. And this is an online program. This is focuses on ecstasy, cannabis, new psychoactive substances. And I suppose this is about that we can also, as well as new technologies posing risks, we can also use new technologies and new ways of delivering prevention in our favour as well. Something which is always a hot topic around drug checking and what's happening in nightlife and festivals. So certainly in the UK, and I suspect the same here in Ireland as well, lots of discussions around drug checking and the legality or otherwise of drug checking activities. But when we're thinking about these sorts of approaches, let's get a bit more creative. This is also an opportunity to engage with young people with brief interventions and preventative interventions. So some work that I'm developing with Professor Fiona Measham in the UK at the moment is trying to understand how we can attach our preventative interventions as part of this otherwise controversial approach. Because quite often the people attending festivals and going to these services have never been in contact with drug or health or social services in the past. They don't offer anything to them. Can we attract them into the welfare or the drug checking tent by using some of these innovations, but actually sneakily deliver prevention and brief intervention at the same time? And personally speaking, I think that's where the value of these sorts of approaches are. Okay, I've kind of got sidetracked as always, running out of time. So what works and what doesn't work? Very, very quickly. So in terms of effectiveness in prevention, We know some types of school-based prevention programs are effective. Those that develop fundamental skills around health literacy, around decision-making, around young people's ability to make sense of health information. We know that they're effective. We know family-based interventions can be effective. So we have presentations from the Strengthening Families program here today. It's a really nice intervention. But I really just want to bring your attention to those sorts of approaches which are ineffective and potentially can be harmful. You can read all about effective approaches, but I think sometimes it's worth focusing on where we can produce harm. And we know, for example, that focusing simply on raising knowledge about giving facts and figures about drug use rarely affects young people's decision to use drugs. It means they're more likely to be able to pass quizzes about drugs knowledge, but it doesn't give them the skills to use and apply that information to their own behavior. So focusing on fundamental health skills is key, I think, even before we start talking about drug classifications or how many people die from taking ecstasy every year. And I suppose my other point, because I am mindful of time, is that we need to be very, very careful about mass media interventions. You know, if I'm going to leave you with any concluding point, it would be about this. Mass media interventions are very attractive, not only to services and practitioners, but also to policymakers and funders, because they reach a large number of people, they're relatively cheap, you can get creative, it's fun, you know, you can get designers in, you can have a really nice time, a really attractive approach. But most of the evidence is telling us that on their own, they're not effective. If you combine it with something else, if you combine it, for example, with a decent schools-based program, if you combine it with community pathways where people who've received the intervention can then go and get some specialist support, that works. Simply doing a mass media intervention can have negative effects, as colleagues in the USA perhaps will attest to, where they've spent billions of dollars on mass media approaches, and a lot of the young recipients actually reported having increased intentions to use drugs. Okay, I think I'm going to leave it there, if that's okay, because I want to leave lots of time for questions. My slides will be available, so you can go through all the different approaches, but I suppose, you know, I really wanted to focus on those broader issues before we even start thinking about what works. So thank you very much.